Stavros, are you ready? Larissa, can you hear me?
Yes, I can.
Yes, I'm here.
All right, perfect, perfect. I felt like I was, in addition to speaking from a void, talking to a void. So thanks everyone. So it's I believe it's 9:40. That's when we're getting started. Welcome back to APIE 2021, coming to you live from said void. This current session will be reviewing endoscopic myotomy after an excellent session last time. I hope we're in line for some more excellent updates, novel technologies, and most importantly, videos. Please remember to use the Q&A function to ask questions or raise discussion points. I encourage the speakers to address questions via the Q&A function and the chat, and we'll try to highlight as many questions as we can during the panel discussion. So with that being said, Stavros, if you want to start sharing your slides. Our first speaker is Stavropoulos, who is the director of GI endoscopy, well known to us all, and the director of the program in advanced GI endoscopy at NYU Langone Hospital on Long Island. And this talk is entitled Poem and ESD Training in the US. Don't just do it. I hope there's an ellipsis afterwards to tell us then what to do. So with that, Stavros, go ahead. Welcome and thank you for speaking.
Thank you. It's great to be here again 2 years later, even virtually. It's a great honor. Mihir picked the title, I think, Poem and ESD Training, Don't Just Do It. I think it strikes an appropriate note of caution. So these are my disclosures. So I'll start with Poem and then move to ESD. It's a data-based talk, no fancy videos. So Poem is a complex surgical procedure with non-negligible risk of operative mortality that is performed quite infrequently. As such, progression to Poem from a background of a safer and more widely available endoscopic surgical technique is indicated, such as ESD. In the NOSCAR International Poem Survey we did of Poem pioneers, and these are pretty skilled people, all the 11 GIs had performed at least 10 ESDs, and 8 out of the 11 had in fact performed more than 50 ESDs before starting Poem. The surgeons tended to come from a different background, but still with another interventional procedure. The 12 out of 14 had done nodes, and 8 out of the 14 surgeons had performed more than 10 nodes. Preclinical training and proctor in this group was important despite their substantial skills. So 10 out of 16 operators in the survey did preclinical training. Most used live animals, few used ex vivo models or cadavers. The extent of preclinical training varied anywhere between 12 and 154 hours. And 9 out of the 16 centers also used an expert proctor for the first few cases, about 2 on average. What about fellowship training? Courtesy of me here, as the chairman of the training committee, we have a core curriculum with core non-technical, technical and cognitive skills. This is very useful for programmatic development of fellowship training in Poem. And we have some fellowship data from Colorado and Emory. This is the Colorado study, 3 advanced fellows over a 6-month period with 1 mentor. Each trainee participated in 10 poems, each after an initial ex vivo model training of 8 procedures. Then they were assessed on 6 cognitive and 6 technical skills on a scale of 1 to 5. This is a very useful tool, I think, developed by Mihir's team. Success was defined as a score of at least 4, with that being minimal verbal guidance to the trainee. And there was very rapid learning of cognitive skills, but the technical skills lagged a little, with 2 to 3 ex vivo procedures and 7 to 8 partially done human poems for learning. The tunnel entry and the tunnel dissection was a little harder to acquire than the myotomy. Although I have to say the myotomy is the more dangerous part for Poem. At Emory, 7 GI fellows trained over 6 years on a total center volume over the 6 years of 153 poems, comes out to only about 14 poems per trainee. And they were in part performed by the 2 expert mentors, but again, the experts themselves had a total volume of less than 100 cases on average over the 6 years. The trainees had a pretty minimal experience of at least 5 ESDs prior to Poem, and the trainees were quoted to be successful in each step of poem after only 3 to 5 partially done poems, and they could perform, quote, a poem independently after 20 cases, unquote. I think this is a bit of an optimistic statement. Which brings us to the question, are these volumes adequate? And what data do we have to go to assess this? So these are the learning curve studies that I summarized in an editorial 2 years ago, starting from 2013 all the way to 2018. Some of the studies are not really very valid, like 40 poems on 3 operators in the beginning of their learning, or 36 poems in 2 operators. That's not enough volume to assess any learning curve. Hopkins had 60 cases on 1 operator with no prior ESD experience, a bit on the low side, and they didn't use a Q-sum graph, they used some inverse curve fitting. They found again, untenably low number of cases. If you need 250 RCPs to be proficient, I don't think you need 11 poems to do that. So anyway, this is our series, 93 poems on 1 operator, efficiency at 40 using a Q-sum graph, mastery at 60 cases. And Shanghai, biggest place in the world for poem, the lead operator, 192 poems analyzed, or 7 other operators, about 200 poems each. They're very massive data. They found on a moving average on procedure time 70 cases, and a composite Q-sum graph for failures and adverse events 100 cases. I'll show you some of the raw data here. This is from a recent publication in GIE. You can see the procedure time in our series of 732 poems over 9 to 10 years. Initially, high procedure times, 150 minutes plus, but rapidly within 60 cases, we drop to this envelope of 60 to 90 minutes. But then learning continues, as you see, beyond the 60 cases or the 100 cases. There was a bit of a stall here when we did our randomized trial of anterior versus posterior. We were not very familiar with the anterior approach, and it's also slower, so that slowed us down. But then after the trial was finished, we bottomed out at a 30 to 60 minute plateau, which is the final plateau, I believe. So you can see the published learning thresholds of less than 20 cases by Hopkins, Northwestern, and Portland, not really, doesn't make any sense. But 60 cases is reasonable, 100 cases also by. And then you can see the Shanghai data here, very nice. The procedure time moving average has an initial plateau at 60 cases, and then another final one after about 120 cases, very similar data to ours. And then the adverse events and failures, the Q-sum graph on that gives a signal at 100 cases. So even in an expert center with a huge volume like Shanghai, 350 poems per year, where the trainees have at least 200 ESDs before they start training in poem, you still need about 100 poems to get really safe and effective. So in conclusion, poem is a complex surgery with significant risk of morbidity and mortality, requiring skills that are underdeveloped among US GIs and surgeons, proficiency in terms of clinical success, procedure duration, and most importantly, adverse event minimization requires about 100 poems. However, training data are limited to less than 10 ex vivo poems and less than 20 human cases. Okay, such training can only be considered a foundation for further self-training and practice towards proficiency in a center that can provide adequate volumes for that and multidisciplinary expertise in terms of motility and other adjunctive services. With an estimated US annual volume of about 3,000 poems per year and a learning threshold of about 100 cases, training and performance of poems should optimally be concentrated at high volume centers and operators. Now let's move to ESD. There are some preconditions on ESD. You have to be in a center where you could conceivably get 2 ESD referrals per month, according to Oyama, but ideally at least once per week. Operator experience is needed in advanced endoscopy and EMR. And, obviously an endo unit that has advanced endoscopy experience, infrastructure, and staff is a must. Now, basic knowledge acquisition, you all know there's plenty of material now online and offline, text, reviews, courses, videos, but it consists of lesion assessment, learning the Paris, Kudo, NICE, and JNet classifications, and then knives and electrosurgical general knowledge, ESD techniques, indications, limitations, risks, and outcomes. So then we get to the preclinical training. Here I'm summarizing basically the ESG guidelines from 2019, very detailed, and the more general guidelines from the ASG from 2020, and also the Oyama article, which is very good and I recommend, from 2015. Preclinical training, ex vivo animal models, maybe non-biological tissue is desirable. You can use your endoscopes from the unit and do a very lab easily even in your office with non-biological tissue. Observe live ESD cases by experts. 10 to 20 cases is recommended. If possible, assist in ESD. That's probably more relevant for fellows, at least 5 cases. And consider a trip to Japan where you can cram 40 cases of observation within 4 weeks usually, which may improve your ex vivo technique as published by Draganov. A cheaper alternative would be if you have Japanese friends that are experts, send them a video of your ESDs ex vivo and they can assess them and tell you what you're doing wrong, as Bat did. Training in live animals doesn't offer a lot more than ex vivo, respiratory movement, and hemostasis, but I don't think it's essential if you have adequate ex vivo training. So when do you graduate to human cases? This is our ESG benchmarks for graduating after hopefully 20 to 30 ex vivo cases. You have to be able to successfully manage perforations, and the last 10 consecutive cases have to be no perforations and at least 80% on block resection. A previous publication from the ESG suggested reaching a speed of 30 minutes to do a ESD of a lesion that has a maximal diameter of 5 centimeters. This is the non-biological tissue model I'm talking about. I used it recently for the track motion. It's very cool, very realistic, excellent conductance. Some of the ex vivo animal tissue models don't have very good conductance. They're difficult to work with, but very good conductance, very good cutting, very good simulation. And as I said, you can use your regular human scopes. Then you move to the clinical training. Probably 40 to 50 cases at least to get to competence. The ESG recommends 10 supervised cases, and the initial cases, they recommend that they are easy 20 to 30 millimeter lesions in the antrum and rectum. The goals here is to have no perforation and an 80% R0 resection rate on these easier lesions. Once you do that, they recommend certification by an expert to move on. Well, they define an expert as somebody with 100 career ESDs. I think that's ridiculously low. And it's also logistically cumbersome to find an expert to certify you. I think maybe more useful is this video assessment tool published by Takao. 28 items graded 1 to 5, and you get a total score, which could be a graduating score and can be assessed remotely by video. Then you continue self-training to competence, which is defined at least 20 consecutive ESDs with on-block rate of at least 80% and adverse event rate of less than 10%. Then you move to proficiency, which is said to take at least 80 cases. This is mainly self-training, and the benchmarks for proficiency are on block 90%, R0 80%, and dissection speed at least 9 square centimeters per hour, and adverse events less than 5% compared to 10% for competence and compared to on block of 80% on competence. So proficiency is a step higher. ESG recommends less than 3% perforations and less than 1% adverse events requiring surgery, as opposed to a general adverse event of 5%. Master classes and additional observation may help now, pick up additional tricks and refine skills. And finally, you reach mastery after probably hundreds of cases. You are an ESD center of excellence involved in training others, etc. Now, the conundrum here is that these guidelines are based on this classic step-up model. First rectum and distal stomach, then everything else once you get good at ESD, or at least reasonably good. The problem with this model is the extreme paucity of gastric lesions. So there is an alternative model, the prevalence-based approach for ESD adoption in the West, proposed by Oyama and others, and I'm quoting him here because he encapsulates it well in how to establish ESD in Western countries. He says early gastric cancer is too rare in the West to achieve a useful caseload of at least 2 ESDs per month. This recommendation, a step-up approach, would impede establishment of ESD for decades to the disadvantage of GI cancer patients. Alternatively, a prevalence-based approach allows for a reasonable caseload, but requires learning ESD mainly in the colon and early on in difficult locations. So there's a downside to it. You get the cases, but they're kind of difficult cases. So I'll show you our approach. I probably was one of the first pioneers in the US to follow a prevalence-based approach, maybe alongside Katzenvoy, with a lot of colon. So you can see after 50 cases, colon became significant. That's the light green of this volume graph. And then after maybe 100 cases, it was the dominant category, the colon. And after 150 cases, very dominant. For the rest of the series, the foregut, esophagus, stomach, and duodenum is little tri-band flag at the top of the graphs here, pretty, low. So you can see how the prevalence-based approach builds volume. And then this allowed us within 3 to 4 years to reach the benchmarks for proficiency. It took about 150 to 200 cases to get to 90% on block, and 250 cases to get R0 of more than 80%. Again, in a series very heavily colon, 52% colon, 88% right colon, and very low foregut, about a quarter of the series. We did also substantial subepithelial tumors. The adverse events, fortunately, were flat even from the very beginning of the learning curve, so we're always pretty safe. Now, this is the procedure time benchmark, 9 square centimeters per hour, which also on this 50 case moving average graph took about 200 to 250 cases to achieve, again, with a very heavy colon series. You can see here the QSUM graphs by organ that give you an idea of the difficulty of ESD in each organ, which shows how many ESDs it took to achieve that speed, the benchmark speed in that organ. It took 280 cases to achieve that speed in the colon, 70 in the rectum, and stomach and esophagus, a little lower. So Westerners must be prepared really for a longer learning curve than the one reported by Japanese studies. So Asian studies have reported learning thresholds for gastric of about 30 to 40 cases, and for colon about 80 to 100 cases. These are likely only achievable in a Japanese training model with continuous tutoring by on-site experts and an abundance of gastric lesions, which allow easier gastric lesions to be allocated to trainee cases during the early learning phase. The highly manipulated Western colon polyps that represent a large proportion of the lesions that we use in a prevalence-based case mix would result in longer learning curves. Amit mentioned this in his commentary, this presentation by Makoto Nishimura, who is a Japanese Asian ESD expert that moved to Memorial in New York in 2018 and presented his initial colorectal data in the US compared to his substantial Japanese data. So 288 colorectal ESDs in Japan, 96% on block resection rate. His first 44 colorectal cases in the US, 72% on block rate. A lot of this was due to previous treatment. On block resection, if there was no manipulation of the manipulation of the lesion, 46%. On block without prior treatment, 84%. Still not quite 96% in Japan, probably because also the body habitus of American patients, fibrosis in the submucosa, and other factors differ from Japanese patients on the bad side. So this shows, the difficulties of a Western approach. This kind of Western prevalence-based mix also affects fellowship training. This is a study by Aihara with his advanced fellow Philip in 2017-18. That year they did 72 ESDs during the advanced fellowship year of Philip, and then you can see what happened with the ESD cases. 9 had no trainee involvement, 19 had observation only, 18 partially performed by trainee, 26 mainly by trainee, but that was defined at least 50% of the case done by the trainee. And you can see here the data in terms of the outcomes. let's say they mainly performed by trainee, which were the easier cases, smaller with much less manipulation, much less fibrosis. So still, compared to a Japanese study of 7 Japanese trainees doing training cases, if you look at their performance on cases between case 16 and 30 compared to the 26 mainly performed by the Western fellow, procedure time 99 minutes here, 51 here, procedure on block rate 88, 100, and complete resection in the West 88%, R0 rate in Japan 96%. Obviously, these are largely easier gastric lesions. So that's the problem, because you have to contend with this prevalence-based horrendous mixed in Aihara's practice of 54% colon, very similar to ours of 55%, 35 right colon, and only 21% foregut lesions, 33% acute, 43% previously MR, very similar to our series actually. So it makes training difficult. How can you accelerate training, especially at the beginner phase? You can, the two things that help beginners a lot is traction, and that also helps experts. And there are 2 studies I quote here for beginners that show that the suture pulley using the overstitch or magnets such as these helped accelerate the procedure for novice operators. And then for scissor knives are helpful because they require much less precise scope, orientation, and manipulation skills to do the incision and the dissection. And that, 2 types, the clutch cutter from Fuji and the SB knife from Olympus. These 3 studies compared, clutch cutter versus flash, clutch cutter versus hook, SB knife versus flash, and they all showed advantages for beginners for these scissor knives in terms of faster procedure times, higher self-completion rate, and less muscle injuries and perforations. So in conclusion, ESD training presupposes mastery of general endoscopy and EMR at least, but hopefully advanced endoscopy. It consists of methodical monitor progression from theoretical knowledge to observation, to practice in animals and other models, and then to easier human cases. The ESD learning curve to very well-defined now proficiency metrics is longer in the West, where an untutor prevalence-based approach requires tackling challenging colon and previously manipulated lesions early in the operator's experience. Despite the longer learning curve in the West, at least 3 years, even with volumes of about 50 per year, a high level, Japanese level of proficiency is eminently achievable in the West as well. Traction techniques and scissor knives may help accelerate the learning curve, particularly for beginners. Now, for those of you who want to watch some live cases of POEM ESD FTR, our live course at Long Island Live only does this kind of cases with experts like Inui, Joe, Yahagi, Katzenvoy, and moderated by Chris Gostow, the big submucosal endoscopy maven. So anyway, you can see it at our site. We have probably 100 cases archived, live cases with commentary from Gostow, and it's available, for free. Thank you.
Thank you, Stavros. That was very interesting, and I think we'll come to some discussion points that have been raised in the chat already when we get to the discussion session, and I'm wondering your input upon training. With that in mind, Mihir, if you want to start sharing your slides.